You're recording now? Yeah. And so we're going to have a chance today to learn from our colleagues at the Public Health Institute about their Together Toward Health initiative. And then we're going to open up the discussion to all of you to talk a little bit about examples of successes and challenges that you've experienced when looking at innovative models to fund work to improve health inequity. So we're looking forward to having a really interesting conversation. If we have time at the end, we'll do a little bit of updates about new events, resources, or other news that you may have for the people who are at our meeting. While we hope today will provide some positive examples of what we can do when we work together, this past month has shown some of the challenges that we continue to face when we're talking about public health inequity. First, over the next weeks, we'll want to assess the impacts of the recent Supreme Court decisions that focused on affirmative action, voting and religious exceptions, and the potential ripple effects that they might have on our work, as well as the issues related to requiring vendors to support gay marriage. So there's lots of things that are public health issues that we really need to think about. We'll also begin to learn about the repercussions of the agreement on the debt ceiling and the funding cuts to critical programs focusing on vaccination and STDs. We're already hearing about the impacts and concern related to that. So we will want to have an opportunity to learn more and hear from you about what's going on. Finally, we have a new CDC director, Dr. Mandy Cohn, and as she begins her tenure, I know that we are all wishing her the best, and hopefully we'll be able to have a chance to hear from her in future meetings. A couple of quick updates. Just so you know, we're not going to have an alliance meeting in August. Look for us to come back in September with another meeting. And if you are at all interested, we hope to see you all in Atlanta for the annual meeting. The early bird just closed, but registration is open. So please take advantage of that opportunity and join us at the annual meeting of 14,000 of your closest public health friends. Now it's my pleasure to hand it over to Steve Greeley. He's going to be leading this discussion around funding models for our work to improve public health inequity. So I'm sure you all know Steve. He's a partner in our alliance work, so he needs no real introduction, but he is the president for Shared Cause, and Shared Cause has worked in strategic planning, partnership, building, and resource development for community organizations. They help leaders develop a comprehensive approach to solving the societal challenges in their communities. So with that, it is my pleasure to turn it over to Steve.
Great, thanks. And it is a real honor to have Mary Pittman and Sue Watson with us today. And I'm sure you all know about the Public Health Institute because it is a national leader in helping communities improve their health safety nets and to address health inequities and promote prevention and quality of care, and does remarkable work based out of Oakland. And so of course, Mary is the CEO, and Sue Watson is leading a very innovative initiative that has important implications about how you design and fund support of community collaboration called Together Towards Health. And so we want to learn from them about their experience in building a partnership around this initiative and how they worked with communities. And so, Susan, why don't we start with you, if you'd like, to give us an overview of Together Towards Health.
Thanks, Steve. I actually think Mary may want to say a few words before I do my presentation.
All right, we'll let Mary do that.
So,
That's great.
yeah, I'll just take a moment to set a little bit of context before Sue does her presentation, and then we'll do some happy to engage in Q&A. But I do want to recognize that Sue Watson wears a lot of hats at PHI and has been with the organization a while. And most recently, she was appointed our Vice President for Racial Equity, Diversity, and Inclusion work at PHI. So I did want to make sure that her new title was acknowledged and recognized, as well as the great work that she continues to do with Together Toward Health. let me take us back to the beginning of the pandemic, and PHI pretty quickly pivoted and tried to figure out what can we do to support public health efforts to address COVID-19. And one of the things that we realized is that there was no way that government could do this work alone, and to be able to mobilize community people and utilize some of the tools and experience we had doing phone surveillance work, that we were able to quickly pivot and put together a strategy to engage community members, multilingual people who understood both the context and the culture of the communities they were serving, and did training programs so that they could be the frontline contact tracers, and then later to also help with vaccine education and outreach. We were able to very quickly scale up a program that had over 500 contact tracers. And what we realized was their ability to understand community and community connection made that program successful. That was our Tracing Health program. And it served as an addition to what the local government was able to scale up and do, and what the state government was able to scale up and do. And we ended up having contracts with many of the local health departments. But it gave us insight into where there continued to be gaps and populations that were not being reached. And we had conversations with a lot of our partners and colleagues, including philanthropy, on how there was a role for philanthropy to help fill in, especially early on. Remember, a lot of dollars flowed, but early on, the dollars were not flowing down, particularly to the local and community providers. And so I have to give some credit to Tony Iton, who's a senior program officer at the California Endowment. And we talked about what roles philanthropy could play. And Tony helped us really get together toward health, going from a funder perspective. And he and I reached out to a number of philanthropy leaders in California, some of whom were focused on health and some weren't, but were concerned about the impact that COVID was having in communities. I'm going to turn it over to Sue, who can talk about the process and the management that went on, both from the funder side and also from the community-based organization side, because both elements were really important to manage and to keep the focus on equitable access and equitable outreach. And we had a tool that PHI had developed called the Healthy HPI, the Healthy Places Index. And that was the basis for a COVID equity tool that the state used. So what we were able to do is have a data-based, evidence-based target for where communities were not being reached. And so let me turn it over to Sue to talk about how we actually were then able to transfer that into action.
Thanks, Mary, and hi, everyone. Happy to be here to share this work with you all. You know, as Mary said, in August of 2020, we launched Together Toward Health to become a statewide initiative to stop the spread of COVID-19 in California's most impacted communities. We do call it TTH for short, so if you hear me use that, I'll be bouncing back and forth. You know, because we were now in August, things weren't going where people might have guessed. You know, I think initially we all thought 2 weeks, we'll be back at work. You know, we knew that a change in approach was essential and urgent. So we acted quickly and boldly and launched TTH in a way that kept the community-based organizations and equity at the center of everything. Of course, none of this would have been made possible without the generous support and partnership of over 20 philanthropic funders who saw the urgency of the moment and contributed to this effort. So let me start with some of the results first, and then I'll back end into pieces of our approach. So we raised a little over $40 million ultimately over the course of this time with our philanthropic partners. Some contributed once, some contributed multiple times. And ultimately, we distributed over $33 million that reached almost 550 organizations in California. For those who know the state, it's a large and diverse place. So to start our efforts, like Mary mentioned, we worked closely with our other program that manages the Healthy Places Index to identify the counties where the disparities were the highest. We met with the local health department staff to confirm what they were seeing as needs and what efforts they were doing, and to really identify how TTH could best support them. We also received intel from our funders and other key stakeholders about important organizations around the state for us to be looking into. And then set out to meet with the organizations, and we funded those who had the capacity and were best positioned to reach the identified communities. And because nothing was static during the pandemic, our approach kept evolving as we continued to solicit input on the local and population-based needs to determine where to make the highest use of the funds. So I shared our primary goal on the first slide about addressing COVID in highly impacted communities. And given where and who we funded, these numbers that come from their evaluation reports really show that we met that goal, and I think, and then some. So now I'll talk about some of the key elements and lessons learned from this effort. Trust is something we heard over and over was the key to the success and outcomes of not only our partner efforts on the ground, but also of the TTH relationship and connection to those CBOs. We trusted that the CBOs were experts in and of their communities. This allowed them to act and pivot based on what they knew to be the best ways to meet the needs of their community. Us trusting them allowed them the necessary freedom to adapt to the moment. This trust also built a sense of partnership. Our team organized and facilitated meetings. We shared resources and funding opportunities, listened and brainstormed with them, and even assisted with advancing their missions and goals outside of their COVID work by tapping into our connections. Ultimately, we prioritized the relational over the transactional, and it paid off. And by the way, you'll see images throughout, and these all come from our partners. So here's a quote from one of the community organizations. It just shows that this trust and partnership meant that many of them confided both their successes and true challenges with us, which allowed us to brainstorm solutions with them in real time. We also removed barriers from the grant-making process by simplifying the application and streamlining reporting. Our application was a maximum of 2 pages long, and the reporting templates provided checkboxes for some questions and focused really on essential information directly tied to our evaluation. We distributed the money quickly with a percentage of the grant funds provided up front. 80 to 90% of the award was provided up front. And the benefits of this approach aren't just administrative. Getting funds out in weeks rather than months saved lives. Local health departments and government funders are often bound by complex requirements that slow the process of applying for and receiving funding. And this flexible model allowed us to move really kind of at the speed of the pandemic, getting the organizations the funds with the flexibility they needed to maximize their impact. And this flexibility and trust also meant that we could support efforts that were rooted in how community members live, where they are, organized by people they trust, and offered in the languages they speak. This showed up as things like music videos, a superhero comic, culturally relevant images and messages using the right terminology and language, and providing incentives that were culturally valuable. And these were often things that other funding sources disallowed. Now, I've been asked about whether the limited reporting or providing money up front resulted in organizations not meeting their goals or inappropriate use of funds. And, going back to that trust element, from our experience, we received 100% of all required grant reports. And we were repeatedly asked questions about, hey, I need to make this shift in my budget. Is this allowed? Is that allowed? Despite us telling them they had freedom, they were still coming to us and asking those questions, showing that they were very interested in being in compliance above and beyond what we required. And so this experience of Together Toward Health, I think, demonstrates how flexible, trust-based grant-making models can empower grantees to innovate and use a pool, and using this pooled fund model really helped funders expand the impact of their contribution. We had contributions that ranged from as little as an independent person just wanted to contribute and they put in $5,000. And then we had some funders, after they put in multiple times, may have put in around $9 million. And so here's just another quote that this small organization was only receiving county funds for their COVID work when we met them. And the payments were taking about 90 days for them to receive after invoicing. So on top of dealing with the pandemic, they had the stress of trying to figure out how to pay their staff and how to make ends meet, because as a small CBO, they don't operate with that kind of financial margin to float in this situation. And so really it was the TTH funds and getting that money up front that provided some relief and allowed them to pick up the pace of their work. And now when I came on board into this, many of us went into this knowing that the relationships between local government and community groups varied greatly. We had counties that had already formed working collaboratives with CBOs that were acting in strong partnership. And we also encountered some where there were historical and current tensions that were blocking the relationships, even in the face of the pandemic. So I made sure we incorporated elements that with the intention of trying to leave things better after we're done. We created spaces to bring all parties to the table, primarily through monthly county meetings, and held them whether the local health departments participated or not. As you can imagine, that varied, but we stuck with it and they were always welcome at the table. And even though we were the fiscal intermediary, we also operated at times as a mediator between the community organizations and local and state health departments and our funders. This reduced the organization's need to be directly involved in potentially uncomfortable political and power dynamics without a buffer. We were able to be that buffer. We worked closely with our state public health department as they had other COVID initiatives operating and had direct access to resources like vaccines and test kits. And so we were able to bring TTH's community perspectives into some of their assumptions and practices that were not having the intended impact on the ground. And we were able to connect our organizations to some of the state's resources and opportunities, including funding that some of them then received from the state. We created learning communities for peer engagement and invested in professional development opportunities for both individuals and the organizations based on what they told us they wanted and needed. And these efforts led to an improved relationship. We still are in contact with several of the organizations, and we've heard from folks, for example, in Fresno and San Bernardino and San Mateo counties, that they now have stronger relationships and partnerships with their county agencies. And there's a more openness to community voices being included. I think in this PHI being this intermediary, as a known and credible entity, it did garner us a degree of trust right off the bat, particularly with our institutional partners. And in this pooled fund scenario, I think one of the things that we really brought into this was that knowing that utilizing an intermediary that does more than pass on funding is a model I think worth diving more into and lifting up. This means that the intermediary itself has to have other assets and guiding principles in addition to strong financial and contractual experience. And, to wrap this up, by doing the things I've shared, many of the organizations in our state who usually go unseen were finally acknowledged, and several have received additional funding from other sources. Some of them have received funding from some of the philanthropic organizations that funded us. Some have received some state funding, and some have been able to apply the opportunities we've shared. Many acquired new skills. We did things like community health worker trainings, mental health first aid certification trainings, and other things. And they formed new relationships, because in those learning spaces, we did it by region, we did it by topic or population. We also did statewide. And so new relationships were formed between organizations, and they continue to cultivate those. Many of these organizations realize their ability to work in new ways and on new topics. Similar to our funders, not all being health funders, many of the organizations were not health-focused CBOs before COVID, but now they're broadening their scopes and claiming seats at tables they weren't previously invited to or welcome at. Several of the organizations are getting more involved in policy and systems change work. And we actually, when we, last fall, we said, okay, we have some resources left. We identified another 18 or some of the 18 organizations, and we talked to them about evolving their strategy into kind of a COVID and really looking at how can they be focused on policy and systems change. And over the past year, we've been providing them with technical assistance around advocacy, what it is to do policy systems change, sustainability, so that as they come out of this, they're better situated, and they're starting to use their voice and their power to advocate for necessary changes. And, I'm probably speaking to the choir here, but I think it's this model of public health that we need to hold on to, one that is grounded in trust and community, so that we can truly build a healthier future for all. And this last quote is from one of the organizations that just really further emphasizes the importance of strong partnerships and community power building as essential elements to make greater progress towards equity. I think you all have been given the link to our website. There's a lot of highlights and a lot of information. And that is the presentation.
Sue, do you
Great.
want to take 1 minute to just tell them about our next evolution in terms of building a fellowship that will address some of the unmet needs that have been identified through TTH?
Sure, happy to. As a result of this, we started to recognize, let me stop sharing. We recognize that there is an opportunity through these essential organizations to provide some capacity building and professional growth through a fellowship. And so we are gearing up to launch the Together Toward Equity Fellowship Program. We're hoping to get applications out in the next couple of weeks so that we would launch this in October. It will be a first year pilot, really engaging with them on what it is that they would want to see in a program like this, but also in us talking about this, learning that while there are a lot of fellowship programs out there, there aren't many that are available or geared towards not the executive director of an organization, but some of those emerging leaders within the organizations. How do we strengthen that pipeline for the future in the skills and the availability of people to continue to lead our community organizations? So we're really excited to be building off of what we did here and bringing this into a fellowship.
This is terrific. I have a few questions to ask, and I might start with the funding component, because it's what you did seems fairly remarkable. Yes, the pandemic was a tremendous emergency, but many foundations and philanthropies stuck with their current programming around the country and just altered their current programming a little bit. Whereas what you did was you engaged funders in public health around a very different model, with flexibility being critically important, the ability for organizations to adapt wherever they felt they needed to changing circumstances, and money up front, the streamlined application process, incredible rapid turnaround in funding decisions, and a lot of small and maybe unknown organizations receiving funding. So some really significant changes to the way things usually work. How did you get the funders on board to do this? What were some of the dynamics of helping a whole group of funders do things in a different way together?
Mary, would you want to add on some of the upfront? I can add on some of the things that we did during the programming.
Sure, thanks. You know, it was a time when people were looking for ways that they could have an impact. And what we did is we went to a few known entities that had trust in PHI. And so it seemed lower risk because they knew that we were taking the risk on, and that we already had a relationship, or they knew enough of us. Most of the initial funders were ones that we had already done work with. So, you know, we knew how they operated. We laid out a few key principles at the very beginning. One, there is no way that we could rapidly do this and have 10, 15, 20 different forms that had to be filled out, you know, for reporting. That we had to have a common set of high-level principles that they would all buy into, so that we were trying to achieve some key goals together instead of 30 or 40 different goals, and pretending that they were doing it together. We also said that we were going to be learning along the way, and that there might have to be mid-course corrections, but we would keep them involved and engaged with us as we learn things. So it was like a no surprise rule, but yet the pandemic brought surprises every day. So kind of at a high level, they had to trust that we would be coming back. And it was very relational. As I said, Tony Eiten joined me, and Tony and I made a number of calls together where one or the other of us had a relationship. And then as the word got out about this, some philanthropies came to us and wanted to know more about it. There were a few exceptions where some of the philanthropies had board required like geographic areas. And we said, that's fine. We'll put the majority of your funds there. But if you're part of a pooled fund, you have to commit to the overall pool. And so a portion of your funds will go to supporting the overall pooled fund work. and we'll recognize, because there are definitely needs in your geographic defined area. And I think that was about the only real restriction that we found. And as I said, not all the funders were health funders. So for some of them, this was more about building community, about equity, about a number of other issues, but they could buy into our core principles.
And I would add that I think for some, they realized they couldn't do their business as usual until COVID was dealt with. And so it was a real incentive to come into something without having to figure it out themselves, that they could contribute to something that was already up and running. I mean, I had a couple of funders that wanted to only fund in Los Angeles. And I said, you can fund the group that we're going to fund, or you can fund TTH. And they wanted to be part of the group. So they chose to put their money into TTH, or one chose to give us money and give the other group money. But it did mean, on top of managing the work going out, that there was a funder management component to this. And it settled into place. It was a little tricky in the beginning. I mean, I'd have meetings, and then people would want their own separate meeting, and there may be one funder, or there may be 4 funders, or there. But I established quarterly meetings for everybody. So we had like clockwork quarterly meetings, and then it became very clear that I think for some funders, this being a level removed took them out of their element. And they didn't know enough of what was going on the daily basis. And so I started doing, I called it Morning Tea with Sue. And it was basically office hours. And so it was every Wednesday morning at 8 a.m. we would have an hour long for whoever could come. And I'd bring in some of the CBOs to be able to talk to the funders directly about their realities on the ground, what their concerns were, how this was helping, so that it was kind of removing some of that barrier. And it really helped, I think, the funders feel more connected and tied in, and which I think built the relationship and strengthened the relationship to the initiative. And so when originally we thought this would end in December of 2021, that was the original contracts. And as we got closer and saw that was not the case, there was a level of trust built with the funders as well. And many of them added more in and re-up so that we can continue working with community organizations, because COVID wasn't over.
Let me augment what Sue said, because it's important to think that program officers have boards.
Right.
And so we made it easy for them with these office hours and these quarterly meetings to have documentation of what was going on that they could lift up and share with their boards. And I think that relieves some of the anxiety of, I'm not directly in contact or in control of where these funds are going. I think there's a second thing that we did from early on, being taught in public health school, that you start an evaluation from the very beginning, is that we got an outside evaluator that could help us both with mid-course corrections that we thought we might need, but then ultimately also having an accountability from an evaluation for these philanthropies, because we had done some joint philanthropic work in other program areas before successfully, and really saw the value of having more than one funder working on something, especially when it was a big problem. And thought we could learn more. And we're hoping that this approach to funding could continue, and that we would need evidence. And I think that that was beneficial as well.
One other thing we did, of course, now it's all coming back to me. Try not to relive all of it, but monthly updates. We sent out updates every month, so that to every funder, And if there were funders who said, like I had one funder in the very beginning said, these are the dates of my board meeting. I'm going to need information. And I just made sure they got what they needed in time for their board meetings. And others might say, my board meeting is in 2 days. Can you help me explain this? Or do you have data on that? So we had, there was a lot of that back and forth, but we were there to support them as well as to support the organizations on the ground.
And we used a lot of brief video clips. So in addition to these paper reports and photos that we used the actual voices of the community members who were funded. And so that was helpful. And as Sue said, you know, her regular meetings with them engaged the community members themselves. So it was in their voice, and then through video, they could share it with their board.
So you really provided a service to these funders in a pretty in-depth way. One of the other things that really struck me as being remarkable, if I understood it correctly, is that rather than having the typical competitive process, you know, making the funding opportunity available and then you say, here's how you apply, but sitting back, it sounds like you also were proactive in going out and not only identifying communities to focus on, but actually helping identify organizations within various geographic areas that might participate. Is that right?
That is correct. I mean, I think at the very beginning, we started with a mindset that it might be more of an open RFP, but I think as it became clearer and wanting to make sure we were not going into local county backyards without them knowing what we were doing, because they were receiving funding to address the pandemic. Some had put some level of funding out to community organizations. We wanted to try to coordinate as best we could. And in order to do that, we couldn't just have an open RFP. So it became quicker for us, I think, in some levels, and more direct to say, health department might have told us, hey, we have this major city covered. We're funding the major groups, but we have no money left and we have nobody working in the outer rural areas. Here's some organizations we're aware of. We would start talking to them. Sometimes we'd ask them, who else should we be talking to? Our funders filled out a spreadsheet of here's organizations we know. And so it was an ongoing iterative process to work with the local health departments as best as possible so they knew who we were funding. We were trying to help bring them all together, but we did not do open application. We just identified who needed to be funded and where and for what and how much.
We also met regularly with the governor's office and their staff, and they would hear things through their own mechanisms and would ask us whether we had the ability to reach out to certain communities, certain organizations, see if, you know, if they fit with the approach that we were taking. And so we collaborated with them. And actually FEMA came into those conversations at times as well and had, you know, other sources of information. So it was really a snowball process to gather as much information and to try to really reach. Sometimes we just heard that a community was unmet and there really wasn't anyone serving that community. And then it was also going back out to see who could stretch and reach a community that was not being served.
Well, the last question I have is, was your technical assistance also funded by this pool fund? Clearly, you played such a critical role to this. Did funders recognize that and allow that to happen?
Yes, we made a commitment in the beginning to do everything we could to make sure that 80% of the funding that came in went out, so that nobody could perceive this as PHI took the money and we only put 10% out and we held on to it. And within that 20%, we said, we have resources to be able to do this. And whether that was, fortunate as a place like PHI, we have a variety of programs with people with different expertise, and being able to tap into another PHI program to say that does mental health first aid certification, and work with them directly and bring them into the process. We paid for them to do that. And then just looking for we had one of our community organizations did community health worker trainings. So we worked with them to provide technical assistance, and the funders had no concerns with that. We just used that pot of money that we kind of saw as ours to cover the evaluation, cover staff, cover the technical assistance, to be providing everything we could back out in service of the organizations.
Does anyone in our larger group have any questions for Sue and Mary?
Denise Smith, do you want to ask the question to the crowd? Okay, Denise is in the car, so she wanted to know a little bit more about the fellowship program, and is it open only to CBO emerging leaders or leaders from all organizations doing this work?
This first year will only be open to the organizations that we're part of Together Toward Health. It's trying to continue that thread of giving back to them. The plan is out years, we will go national, and it will be more open and broad. And we have not defined that you have to be a health organization, or, we haven't defined that you have to have a master's degree. We really want to recognize that people are coming from all different walks of life, and people have joined into this with all intention and in that greater sense of public health. All of these organizations are needed.
And Denise, we'll come back to you for, helping us disseminate this, after we're probably, 7 or 8 months into year one. We will start the process for the following year on a larger scale.
Congratulations on a spectacular initiative. It's a lot of lessons for us to learn from. And I'd like to maybe turn to some members of our group. Laurie, I'd like to offer a comment or a question.
Yes, good afternoon. Let me just turn my video on here. It wasn't a question. First, I wanted to just, I'm Laurie Freeman, CEO of National Association of County and City Health Officials and NACHO. I wanted to just comment and thank you for the intention that you used to engage with the local health departments and in this work. Most of you, of course, that work in a space realize that these partnerships are they're commonplace in communities, in most communities, and they're used at different times for different reasons. But 3/4 of our health departments have very intentional kind of agreement, MOUs, strategic work with community-based partnerships, and I think 92% have some engagement, may not be as formal. I think the other comment I wanted to make is just this piece on the funding, which I think is really important. During COVID specifically, I know we were approached a lot about the sharing of funding to deepen community reach. And I think there was a lot of recognition that was an imperative during COVID, but at the same time, we didn't have a lot of money reaching the local health departments in order to share. There just wasn't enough money to go around in some cases. So I like this opportunity to look at getting resources to community-based organizations differently. The other, it's a huge opportunity and a good one, and we all know the benefits of this work more deeply in community. We know that the community-based partnerships are absolutely necessary, kind of the last mile approach to deepen reach and impact of the public health work into community. I would say the challenges that both NACCHO had and our members had when we did fund community-based organizations were mentioned here. Like some of them, many of them might have been newer. Some weren't administratively able to do it to meet the demands and requirements. I would love to see some sort of a collective effort by groups like ours to really try to approach the government about and the OMB rules to change some of the stringent federal requirements for granting and subcontracting, subawarding funds, because this is a huge barrier for us to do our work as well. And we found ourselves really often on the edge, even at NACCHO, of, risking an audit finding in order to do this work. And we don't want to put ourselves there, and we certainly don't want to put our community-based organizations in that position either. So seems like a great model. I'm really looking forward to hearing more as it goes along, and if there's anything that NACCHO can do to help facilitate this work, I hope you'll let us know. Thank you.
Mary.
Yeah, Lori, thank you so much for your comments. I think we recognized that there were some, limitations. There were certain things government couldn't do or couldn't do in a timeline, or there were certain risks that they couldn't take. And to me, that's the perfect partnership between local government or state government and what I'll call a fiscal intermediary plus, like PHI, where we can not only get money out for you, but we can do those other wraparound services to try to strengthen the parties that you're funding. And we took on some of that risk. And I have to say, in some cases, it wasn't easy. Our grants and contracts people had to do a lot of education, a lot of hand holding. And, we thought that it was worthwhile, but you did have to have a certain level of capacity to be able to do that. So to me, this is not only a good example of partnerships between philanthropy and local government and a fiscal intermediary like PHI, but also between the local health department and a fiscal intermediary and those organizations, because we can't expect government to do some things that are beyond what their regulatory or even their comfort level is and who they have to report to. So to me, it was like a perfect opportunity to blend the strengths and the limitations of all parties.
I would just add one thing there for Lori. One of the things we heard definitely from some of our health department partners was that they were able, because it was deemed an emergency, there were things that they were able to do that streamlined their processes. And so for some, they're like, oh, I see we can actually move this faster or do certain things, and that they're trying to now work to say, how do we retain some of these pieces? Because, we found that we can do more than we thought we could. And I don't know what kind of success they're having, but I'm sure any help from NACCHO on how to streamline agreements, or what parts of the emergency actions should we be looking at as being permanent.
Yeah, there was a lot of expanded authority and things that we don't usually have available to us. But those things are, they come and they go, and it always feels like you're in a risky territory sometimes when you're in an emergency and things start getting clawed back too, and you're not really sure where you're left with some of these buckets of funding and what kind of authority you have. I think there is more we can do, though. You're right. And there, I just wanted to let you know, there's a real desire to do it too. I think, there isn't a health department in this country that doesn't recognize the need and the power of partnership, and the need to share the power, as you mentioned as well, in order to get at that trust rebuilding that we have to do, that we lost so much of during the pandemic. That is a key part of the rebuilding of the trust. So thank you.
Any other input from our larger group? Models you'd like to discuss that you feel we should be looking at, or just future additional questions?
Judy Monroe.
Yes.
Hi, can y'all hear me?
Judy, go ahead.
Yeah,
Yes.
hi. So Mary and Sue, congratulations. It's great hearing about this. I knew you all were doing this, but hadn't heard the report out like this before. A couple of questions, a few comments, and kind of building on where Lori was going as well. But first question, I may have missed it on the front end. Did you say what the range of awards were when you gave the grants out to the the CBOs? What kind of range was there? Because they weren't all the same amount, I wouldn't imagine.
They were not all the same amount. We really tried not to go below $50,000, but on average, I think the awards were around 100. And that when we received additional funding going into 2022, we increased funding for several people. So I'm not exactly sure where we landed, but we were hovering around the average of $100,000.
Okay, great. That's helpful, and that's consistent with a lot of our experience. So a few things to unpack here to put a fine point on. You're bringing up the issue of an intermediary that has that capacity to be able to give the technical assistance, which has been our experience at the CDC Foundation as well, particularly during COVID, but other experiences where it becomes quite beneficial. But there has been, as you all know, there's certainly in some circles a movement to funding directly the CBOs without that support of an intermediary. And so I think there may be even a larger paper here, or lifting this work up from multiple other intermediaries across the U.S. And I don't know if you've reached to others about this, but your experience resonates with me from our experience at the foundation. We were fortunate on the front end. So we were the tale of all cities, a tale of more than two cities, I think, here. On the front end, we leaned in hard and fast, and it was certainly an advantage having CDC in our name to do the fundraising. And so we were fortunate to bring in unrestricted. So we didn't have specific donors. We brought in a lot of unrestricted funding under COVID that in turn we put out the door to CBOs, as well as local health departments and other partners that we got out the door. And the beauty of that was that honestly, we didn't have to report back to specific donors because it had come in completely unrestricted, a lot from individual donors or different fundraising mechanisms. That was a sweet spot. I mean, that was like amazing, right? To be able to really push the boundaries on speed and targeted funding and so forth. The flip of that is we also had federal funding that went out to CBOs for vaccine confidence and so forth. And it's exactly what Lori was talking about. We ran into, we actually internally ended up having where our compliance team was incredibly restrictive and worried about, risking an audit and having issues where our folks deeply embedded in equity and community were going, no, we have to be, we need to get more of the money out up front. Like you were saying, you're 80 or 90%. They need the money up front. We can't do what the federal government's saying. And so it became a real point of contention actually internally. And I think that's one, I agree with Lori and others that have said this. We need to work with federal government. However, the other side of the coin is, I don't know how much you all are reading, and I don't know if APHA or others have done the analysis of this, but I've certainly seen enough articles just recently about the amount of funding at large that went out the door to cities and states and whatever, and how much fraud there was. And so all this money is flowing in an emergency. And so you do have that tension, right, of the fraud and the misuse. Whereas what you all are describing, which is consistent with our experience, is those trusted relationships and building the partnerships where, quite frankly, I mean, it's even hard to imagine that some of these CBOs would even think about misusing, right? To your point, they want to actually deliver more than the value of what you've paid them for, which is obviously the place that, would be fantastic if we could get to as a country. But we've got all these actors that don't necessarily align with that. So any just a few thoughts, and any thoughts about how we might be able to thread that needle between the federal funding and the restrictions, because it puts quite a burden on the CBOs as well as health departments. I mean, sometimes the juice isn't worth the squeeze for the funding, and that's a real shame. I'll stop there. There may not be any.
Janet Hamilton, you have your hand up.
And I had a different question, actually. And Judy, your questions are spot on, as always.
Judy, I'll just say that, as an organization that gets a lot of federal funds, we always had to balance, compliance, and, we kind of kept separate these philanthropic dollars where we had a different level of flexibility from what we were doing with federal funds. We didn't see a way around that, and I don't really see there being a lot of interest at the federal level. I think it's going to take a lot of education and a lot of work to be able to get greater flexibility with federal funds. But I think the case for the need at the local level and finding some new mechanisms to get those funds there. I think the challenge is it's going to be hard to get federal dollars directly to some of these small CBOs, which does
Right.
you for some sort of intermediary. And I would be willing to work on making the case to try to free up some of the compliance knots that make it difficult to get those dollars through. And I'm always the optimistic person. I'm just not sure that we're going to see big movement. I know, Janet, you've got something else that's more positive.
Janet, we're almost up in time.
Yeah, I recognize we're at time, and I just really wanted to say, I think kudos for also really thinking about the fellowship program in addition to all this incredible work. CSTE, as some of you may know, we offer a fellowship program that is designed not for those senior folks, but really the mid-level folks with MPHs that really want to work in health departments and work in epidemiology. And I think we have this incredible interest, but not the funding and support to meet that need. So health departments want them, and we have these amazing folks that want to go, but we have this funding gap associated with it. And I just think it's so critical that we really work towards, as you all are doing, funding these other kinds of leaders and opportunities, and really helping those community organizations grow. So just want to say thank you for that.
I will say that the initial year we are funding out of our net assets as an investment in the future, but we are fundraising for the future. But this first year, we've made a commitment out of our own funds to see this happen.
All right. great conversation, and we really are privileged to have the opportunity to learn from you. Thank you so much for joining us today. Any final words?
I was going to say thanks to everybody, and we are not having our meeting next month, so have a great rest of the summer, and we will see you all in September, and thanks to everybody. And thanks so much, Mary and Sue. That was great.
Thank you.